Hello, welcome to my presentation for NU 726 epidemiology. I will be talking to you today about what's probably on all of our minds, the novel coronavirus. I first got interested in this when my son called me out of the blue in January asking if I knew what was going on in China. And I said, well, no, not really. I heard a few things, but no, I haven't been paying attention. And he'd been looking at it and reading about it, and he said, and by the way, you're not going to have any of those N95 masks. I'm like, how do you know about N95 masks? Well, the company he works for imports and distributes products like that. And at that point, they'd been on back order probably a month already. So I had an inkling that this might be a lot bigger. And of course, always thinking that, well, I'm sure it'll be like, some of the other things where it stays over on that side of the globe. But here we are. So come on along. I've learned a lot of things over the course of the time that I've spent reading about this and talking to people about it. So yeah, hope you enjoy. So in December 21st, health facilities started reporting clusters of patients with pneumonia of an unknown cause. This was in Wuhan city, linked to a seafood and wet animal wholesale market in Wuhan. That's in the Hubei province, China. So Chinese CDC dispatched an investigation team. We have this information from Zhu et al., and this was published in this January, the 24th. And what they did is they outlined the 3 cases that were identified as being positive for this novel coronavirus. So 3 patients present, 12, 27, 19 with severe pneumonia. A 49-year-old female, that's patient number 1, no underlying chronic conditions with a fever, cough, chest discomfort since the 23rd. Chest CT reveals she has a pneumonia and she was a retailer at this seafood market. Patient number 2 is 61 years old, male. Fever and a cough since the 20th. So he's now on day 7 and he's developing respiratory distress, and it worsened over the next 2 days, and he was intubated and ventilated. He was also a frequent visitor to this market. Patient 3, a 32-year-old male, and there was no clinical profile available. So patients 1 and 3 recovered. They were discharged from hospital on the 16th. So they had been there for approximately 3 weeks. So the outcome for patient 2 was not good. Patient died January 9, and that was 20 days after onset. You can see the x-rays on day 8, that's letter A, and as well as 11, that's letter B. And this is after onset of illness. The authors describe the findings that they're noticing an increase of these fluffy opacities in density for perfusion and confluence at that second X-ray at day 11, with the most marked changes in the lower lung fields. They obtained lower respiratory tract samples using bronchial alveolar lavage and extracted nucleic acids for real-time reverse transcriptase polymerase chain reaction testing and culture. They identified a beta coronavirus with 85% similarity with bat SARS-like CoV genome and named it 2019 nCoV, or novel coronavirus as it became known. Li et al. Looked at early transmission dynamics in Wuhan, China, and everything is laid out very nicely. You've got the pneumonia cases linked to the seafood market, the case finding, and they close the market and start emergency monitoring, case investigation. Everything looks really picture perfect. They also let World Health Organization know, and what's really interesting to me is they got that gene sequencing completed, but that was on it looks like around the 1st of, actually, no, the 3rd of January. But they didn't share that until around the 9th. And some of the critique about this, and some of it harkens back to the days of SARS Classic, where China was not forthcoming with information, and they were trying to minimize what was going on. And I do recall, I mean, who of us will forget the physician that sounded the alarm, and next thing you know, he didn't survive the disease. So it's fraught, and I do acknowledge that. What we are going with is that they did release that genome, and it was released to a very reputable, um, collaborative association. And so I think, again, I wish we could turn back time. All of us do, and do things differently. But it is what it is, and we're going to move forward with that. They released the information to the Global Initiative of Sharing Avian Influence Database. And this is truly marvelous work by dedicated people. It is an international collaboration. It's based out of Germany, and there are a lot of people working on this in overdrive, pretty much. So they have sequenced 848 genomes that have been sampled from December 2019 through March 11 is where I'm at here with when I did my screenshot. So this is their website is, you can go there, you can click on all these things and have a look. So if you're on that page and you just scroll down a little bit, you can click play, and then you can see how the spread happens and watch it populate. SARS-CoV-2 is a lot like SARS-CoV-1, or SARS Classic as it's known in epidemiological circles. And it's also related to MERS-CoV. That was based out of the Middle East. Didn't really reach North America. However, their mortality rates were staggering. MERS is 34.4%, and SARS Classic 9.5%. So they were pretty lethal, which they killed their host, really is what happened. And I think what we're dealing with now is this brilliant coronavirus who has figured out how to be a common cold while packing a massive punch for a certain subset of whatever population they're dealing with. And I just really want to clarify that it is nothing like seasonal influenza at 0.1%. 0.1% is plenty. In this country, that's a large fatality rate. So when you get up into the 9.5%, 34.4%, that's huge. With what we're looking at right now with the coronavirus, the novel one, again, coming out of China, 2.3%, but it's going to vary. And this is the thing, this is an evolving number, and it's going to depend on how well we do this. So here is a paper from Munster et al., and it includes one of my favorite authors. I follow her on Twitter. All right, so Twitter's become like my new search engine. I gotta be honest with you. There are some amazing epidemiologists on Twitter, and they freely share, and there's great, interesting information coming from them. I've had more brand new studies than I can even read by following several of these folks. But anyway, okay, that's it. That's it for my fan club part. But they looked at the pathogenicity and transmissibility characters of recently emerged viruses in relation to outbreak containment. And as you notice, this came out, it says February 20 here because you know what? That's when they actually published, but the actual information came out January 24th. This is shortly after our first documented case. So 2019 NCOV, that's what we called it still, we just didn't know much. And we still got efforts ongoing for the contained part. And then you drop down to SARS Classic. It's actually been eradicated, and they haven't been able to trace it anytime recently. And also they got MERS, and that is not contained. And so again, that's still on the horizon. But I think what I found most interesting are the remarks over on the right-hand side. 58% of cases for SARS Classic resulted from nosocomial transmission, and MERS, 70% result from nosocomial transmission. So I want you to tuck those numbers away because we're going to talk about a lot of things as we move on. But to me, from a healthcare worker, provider, whatever name you want to call yourself, we're in the hospital setting, we're the nosocomial people. These things really matter. And I think we got another one of these on our hands, to be honest. And I think we have to be very proactive with protecting anyone that works inside of an institution, such as a hospital. Here's the Johns Hopkins COVID-19 tracker, and I'd recommend, if you haven't had an opportunity to look at this, this is probably the most reliable resource out there in terms of overall numbers. So we got total confirmed cases over here on the left. You can scroll by country or you can click on the map. It's interactive. Over on the right is the total number of deaths in white and the total number of recovered, and that's the green. And you'll also see that there's a green line underneath on the right, and that's the total recovered. The orange line is mainland China, and that's basically is the benchmark. And you can see that the yellow line are other locations, and you can see that that is spiking up. And especially what I've been watching over these many weeks now is just the devastating situation in Italy. Their case count right now is 53,578 with a death rate, or the number of deaths, 4,825. So they've actually surpassed China in the number of deaths. So just looking at case fatality rates, because this is going to come up in the data that we're looking at, that is the number of deaths over the total number of cases. So the ones that have tested positive for this virus. And you can see South Korea, they're sitting at 0.6. Italy, I will tell you, their rate is much, much higher than that now. These values are from March 2nd. China is at 3.6, but it probably reflects more the impact of that is across the board in China, whereas if you were separated out by provinces, most of the provinces other than the Hubei province are probably less than 1%, because the Hubei was the epicenter of this emerging disease. Iran, you can see, has come down, and part of that is likely once you start testing and you get your numbers spike, but until you get enough cases, it's going to look like you have a very high mortality rate, and they're sitting at 4.4, which is still pretty. That's still pretty high. So just for some perspective, we'll look at the case fatality rates of the seasonal flu here in the U.S. and the COVID-19. Seasonal flu, as we know, it hits older folks harder, and so all ages is 0.1%, with 65 and plus it's 0.8. For COVID-19, based on data from a Chinese study, they're estimating the case fatality rate to be at 2.3, and for those 60 and over at 6%. However, those 50 to 59, it's still 1.3%. And, you know, the one that I find interesting here is 20 to 49, 0.3%. So that is 6 to 16 times higher than the flu in that age group. So that bears thinking about, because I know the story is, well, it only hits the old people. And, I'm in my 20s, I'm going to party on the beach. But I really think we need to definitely be thinking along these lines that, yes, they can definitely get sick with this virus. So the thing to keep in mind is that the case fatality rate is a moving target. It's going to be shifting and changing. Generally speaking, countries that are prepared are going to see a lower rate, such as South Korea, and countries that are overwhelmed are going to have higher case fatality rates. And that's exactly what we're seeing. And we'll look at some charts in a little bit. All right, so COVID-19, again, that's the disease, not the organism itself, but we're going to talk about transmission, risk factors, containment, mitigation, as well as testing and reporting data. So to look at transmission, we're going to be looking at Wu and McCougan from their report from February 20th about characteristics and important lessons from COVID-19 outbreak in China. It is a summary of a report of 72,314 cases, and that is from the Chinese CDC, published in JAMA. And they state the sheer spread of both the geographical expansion and sudden increase in numbers of cases surprised and quickly overwhelmed health and public health services in China, particularly in Wuhan City and Hubei province. Epidemic curves reflect that what may be a mixed outbreak pattern with early cases suggested a continuous common source, potentially zoonotics spillover at Hunan seafood wholesale market, and later cases suggestive of propagated sources as the virus began to be transmitted from person to person. All right, so Wu and McCougan looked at the characteristics of the outbreak in China. Looking at age distribution, you can see the bulk of the cases were in the 30 to 79 age range, but there was an 8% of the cases were in the 20 to 29-year-olds. Spectrum of disease, they classified as mild for those that came in with a fever and a cough, but with no evidence of pneumonia. So the majority landed in that group, 81%. Severe, those are patients with presenting with shortness of breath, along with the fever and cough, along with increased oxygen needs and lung infiltrates 24 to 48 hours out. The critically ill patients have respiratory failure, septic shock, multiple organ dysfunction, and this represents 5% of cases. Case fatality rate, as we discussed earlier, was 2.3% across the cases, and of course higher in the older, 14.8% for the 80 and older, 8% for the 70 to 79 years old. Now in critical cases, case fatality rate is 49%, so that is pretty significant. They also looked at healthcare personnel infected, and out of their group of 44,672, 3.8% became infected with the coronavirus. 63% of these were in Wuhan, which raises a lot of questions about how well quarantining, forced quarantine, actually works. So that's definitely something to be thinking about. 14.8% were classified as severe or critical, and there were 5 deaths, which would bring the case fatality rate for this population up to 2.9. So there's definitely increased risk with being a healthcare personnel. So one of the sites that I found really helpful is Our World in Data. The authors, Rosen et al. are doing a lot of work pulling together or aggregating recent research and presenting it, creating a synopsis with a lot of really great charts. And I've just really found this one very, very helpful. So, risk factors for COVID-19, the top one is cardiovascular disease at a whopping 10.5%. I mean, that puts us in the neighborhood of SARS, just with that comorbidity. The next one, diabetes, 7.3, chronic respiratory disease, 6.3, and hypertension is right there at 6%. I saw another study where they had it a little bit differently, had the hypertension up, and again, depended on the numbers and the study. But what I find interesting is cardiovascular disease, diabetes, and hypertension all have an inflammatory component to it. So, in looking at our population, I don't think in my day-to-day life, I always have patients of a certain age are all taking medications for either one or two or more of these conditions. Of course, cancer, the immunosuppressed, that's definitely concerning. Without any underlying health conditions, the case fatality rate is 0.9%. So when we talk about containment and containment strategies, we think about immunization, which of course is not an option. Here we don't have that. Infection control measures is where we go next. So surveillance, epidemiological investigation with case control, control contacts, sample testing, quarantine, and notifying appropriate agencies. And I think that all of us can agree that we have left the containment phase and we're on our way, and we're actually in the phase of mitigation, which we'll talk about next. But I just wanted to reveal to you one of my favorite sources throughout this process has actually been hashtag EpiTwitter, where epidemiologists, virologists, other scientists, folks that really like statistics, are in conversation about what's going on in real time, pretty much. And so I found this, and this was kind of making the circle, or a lot of comments about epidemiologists are the new rock stars. So this is from a New York Times op-ed, I believe. I actually haven't read all of it, but the thought here is that the administration is still talking containment. Epidemiologists in the main are assuming it can no longer be contained, that we should be all responsibly thinking about next steps so that hospitals don't become overwhelmed. Many of them are worth following on Twitter. And so it was funny, it made me chuckle. This was back on March 10th. And because at this point I had already found several that were just so fascinatingly interesting in terms of what they were talking about and discussing some of the issues. So yeah, so I'm an Epi Twitter follower. So we move on to mitigation. And again, this fabulous graph over here is something I found on hashtag EpiTwitter. This is when containment is no longer effective. Testing of samples, well, we know that we haven't tested enough here in this country. Quarantine, limited effectiveness. But where we are going with this, and you guys have been hearing this already, social, or somebody said physical distancing. I think I like that term a little bit better. Cancel culture, flattening the curve. Now, here, this is Anne-Marie Darling, an epidemiologist that's on Twitter, and she says lots of sciencey folks are posting this graph, but if there's one thing I've learned from being on the internet, it's this: data, graphs, not compelling to many. Kitties, compelling to many. So I present flattening the curve. So here's the alert: kitty outbreak will pounce and shred the healthcare system like the arm of your couch. The lazy kitty outbreak, the long intervals between transmission events, like the amount of time this kitty will hold this position. it'll allow the healthcare system to cope. So I really appreciated this because this is a very, as you can well imagine, this is a very heavy subject. You're all feeling it, and I just really, so this kind of made my day. So here we have it. We are finally on the road here. We're starting to get more testing done. And what we're finding is, yes, it's a fairly steep upswing. So why outbreaks like coronavirus spread exponentially and how to flatten the curve was a lead article in the Washington Post. Let's see, was that March 13th? Yeah, I think it was around then. But it's an interactive, actually, it's a simulator of, so what it does, it has little bouncing dots that bump into each other, and it simulates how transmission occurs if you do nothing to mitigate it, if you don't work on flattening the curve, if you do if you quarantine, what happens if you do if you do some distancing, social distancing, and then if you do a lot of really work on the distancing part, and just how you can shift the shape of the curve. And again, the big goal here is to reduce um, the demand on the healthcare system, because we will not be able to handle a tsunami of cases all at once. So this is somebody else that I've been following, Bern Murdoch. He is a statistician, I believe, working for Financial Times. And so what he's been doing, he's been using the data from the Johns Hopkins dashboard, and he has been putting it into a logarithmic graph. He feels that's more, it gives you a better idea of progress than a linear one would. And so you can see here, it's a little busy over there on the left, but if you look over to the right bottom, if we start from the bottom and you see Hong Kong and Singapore, they have a very low, their curve is not very steep at all. So this is a little different than flattening the curve, again, because we're logarithmic here, but you can see that the 45-degree angle here on this graph is a 33% daily increase. So these countries are all well below that level of daily increase in new cases. So Hong Kong and Singapore, what did they do? They had early school closures, they quarantined. Singapore had strict quarantine, but also in Hong Kong, it was a huge community response. So this was not a sort of policed, mandated shutdown. It was very much, the community was very much a part of it. And they did not implement those types of measures to make that happen. Singapore, again, they did contact tracing there. Japan, strong social norms around obedience and mask wearing. One of the most interesting stories to me is South Korea. They had a huge test and trace program, and they got on top of that right from the get-go. They had their first case right around the time as the US did, and they took a very different approach from what the US has done. And so the lodestar is, of course, China, because that's the epicenter, that's where it started. We've been watching that develop now for the longest period of time here. And China is also flattening out. Their daily increase has gone way down. In fact, they had a few days there without any new cases just recently. So then do have a look at the US graph. It's the pink one, and it's the one that's above the 33% daily increase. Now, part of it is we're late to the game with testing, and so that's going to be artificially inflated a little bit. But again, it does not look like the slope of that trajectory is deeply concerning, especially when you consider where Italy is and how rough it's been in Italy. So we'll talk some more about that in a minute. So Italy, oh my word. It's really been devastating watching this from afar. They do have a large elderly population, which would contribute to having, a lot of comorbidities along with the age card. But they've actually topped China, as I mentioned earlier, in terms of the number of deaths, which is incredible when you consider that Italy's population is only 60 million. And so I can't even imagine what the families there are going through. That being said, Italy and Spain, both of those countries, their trajectories are of, the deaths are increasing a lot more rapidly than what they did in China. So we as the US, and you can see the US numbers starting to uptick, this is the time. If there is a time for us to implement interventions, this would be it. So all of us have to get really serious about flattening that curve, telling our family, our friends, people we don't even like, tell them. No, this is real. There's a time frame here. There's a window of opportunity, and if we can take it, I just want that message to get out that we need to do that. So we're just going to do a quick look at why transmission is so exponential. So early in the break, this is Adam Kucharski, who is a mathematician, epidemiologist at the London School of Health and I think, yes, tropical medicine. So he's based out of London. So it's estimated that the RO of this disease is approximately 2.5. So one case infects 2.5 on average. So let's say there's 5 days between one infection and the next. And if you counted that over a month, it's going to be 2.5 times 2.5. And then the product of that is going to be times 2.5. So you do that 6 times and you'll have 244 cases in a month. Now, if we can drop that transmission so that each time the case infects only 1.25 other persons, then over that very same period of time, we would only have 4 more cases, which when you think about our healthcare system, having 244 people coming into your ED versus 4 makes a huge difference. He goes on over on the right side. There's a thread that he follows through, just explaining a little more, saying even if we can't fully stop this, if we can sustain changes in our behavior, so self-isolation when you're ill, keeping going with that hand washing and reducing close interactions, it could actually really dramatically reduce spread. So we know this is where we are. And it is important that we all do recognize how significant this is, especially at this point in our country. I know several areas are being hit harder than others at the moment, but we really need to look at this as a community up here where we are. So again, it's a modeled calculation that he's dealing with. The 2.5 is the RO of this disease that they have calculated. And of course, to get total cases overall, you'd have to add the generations of infection. Still, the big message is we've got to stop, or we got to reduce transmission. So this past week, 3 really interesting papers were onboarded. One of them is by Van Dormalen, and I think you guys have heard about this already. And I'm terming this airborne isolation. I know there's a lot of debate about this, so I'll just talk a little bit about that. So I'm quoting this from their medRxiv piece. I know it's now been published in New England Journal. But what they did was they looked at the aerosol and surface stability of HCOV-19, or the SARS-CoV-2, and they compared that to SARS-1, which is, some places call it SARS Classic. And they found that the stability was really pretty similar. And viable virus could be detected in aerosols up to 3 hours. post aerosolization, up to 4 hours on a copper surface, about 24 hours on cardboard. And again, in their published piece, they give a few specification that that's not as reliable as the other measures, and up to 2 to 3 days on plastic and stainless steel. They also exhibited similar half-lives in aerosols. The median estimate's around 2.7 hours. So that's a really important thing to know, that even at that 2.7 hours, it's going to drop by its half-life. So it takes a long time for it to really actually clear. Relatively long viability, stainless steel and polypropylene in comparison to copper or cardboard. So here they have it estimated that it's 13 hours on steel and about 16 hours on polypropylene. But the really big deal with this study is that it indicates that aerosol and fomite transmission of HCOV-19 is plausible, as the virus can remain viable in aerosols for multiple hours and on surfaces up to days. So I've just put a quote from their New England Journal um, publication. And so they repeat, the results indicate the aerosol and fomite transmission, same as in their preprint. But since the virus can remain viable and infectious in aerosols for hours and on surfaces up to days, depending on the inoculum shed. So they put a little qualifier in their published edition that they didn't have in their preprint. So these findings echo those with SARS-1, in which these forms of transmissions were associated with nosocomial spread and super spreading events, and they provide information for pandemic mitigation efforts. So I think it's important to note that they made this amendment to their final piece for publishing. And in their closing remarks, they also state that the findings and conclusions in this letter, because it was published as a letter to the editor, are those of the authors and do not necessarily represent the official position of the Centers of Disease Control and Prevention, and that would be the American one. And one of the authors of the study works at the CDC, so I do find that very interesting for one. But I also, from our perspectives, being the frontline workers, knowing that we are already at increased risk for infection and also increased risk for getting sick because of our exposure, we really, the other really big piece that I keep thinking about is everybody is saying, well, it's okay to do this sort of intermediate elevated droplet isolation, and it concerns me deeply when we know that both SARS and MERS had really high rates of nosocomial transmission. And just reading a piece earlier today where Italy has really experienced a large amount of nosocomial transmission during their experience with the coronavirus. So I think we do need to exercise caution here, and we can't predict super spreading events. We can't predict which patient is going to self-extubate. We can't predict when the vent tubing is going to come apart or a patient pulls off their BiPAP. How many nebulizer treatments are we going to be needing to give these folks? That's, I'm thinking very clinically about this. And I also know how not good we are with our isolation practices. And the other piece is we don't have the equipment that we need. There is not enough to go around for us to actually be consistently with an airborne transmission. So there's a lot of debate about this. There are those, again, it's a really hot topic, and I would rather we err on the side of protecting our healthcare workers. And I mean, that includes not just the nurses or the care aides, but it also includes all the mid-levels, the docs, and environmental service folks. This is something we really need to take seriously, I think. So needless to say, this article has gotten a lot of traction, and Dora Mullen sent a link and an endorsement. She tweeted another great write-up by Wired Science, and so Wired has did a did a write-up on this article that they published. A lot. It's in a lot of places. You guys have heard all about it. But one of the most interesting reads is by Kamsi, and this is from Wired, March 14th. They say coronavirus isn't airborne, but it's definitely borne by air. The word airborne means different things to different scientists, and that confusion needs to be addressed. So it's one of the best pieces that I've read looking at, to say that something is droplet or it is airborne. I think there's a huge continuum there that we don't even really quite understand exactly, especially with this disease. But and the fact that it's so unpredictable when something is going to be aerosolized. Let's say they do have a really big cough, and you say, oh well, it's only going to go 6 feet. I think the 6 feet and the 14 days are both things that I'm not sure if we're not basing that really on the history of this disease. I think that is based on other diseases that we've worked with. Enteric testing and precautions. Chow et al., in their evidence for gastrointestinal infection of SARS-CoV-2 in medRxiv, it's in preprint, had some really, really important findings. The parameters for taking somebody out of isolation is that you need a negative result of your PCR testing from at least 2 sequential respiratory tract specimens collected 24 hours apart. And that would be the standard would then be to discontinue isolation. What they found was that more than 20% of SARS-CoV-2 patients, there was viral RNA, and they were still positive in the feces, even after a negative conversion of the viral RNA in the respiratory tract, which would indicate that the viral gastrointestinal infection and the potential fecal-oral transmission can last even after the viral clearance in the respiratory tract. So their strong recommendation is for PCR testing of the feces, and that should be routine, and that transmission-based precautions for these patients should continue if they test positive, as this could result in fecal-oral transmission. So this is really something we need to make. We're focusing very much on the respiratory issues, as we should. That is their chief complaint usually when they come in. But to also keep in mind whether they have gastrointestinal symptoms. And I mean, I don't know that we're going to be getting to do this routinely. It'd be great if we could. I think it's really important. And, talking about aerosolization, I can't think of a more aerosolizing process than flushing a toilet. So I really, again, this is a really important piece as well. In their paper looking at the clinical course and risk factors for mortality in adult patients with COVID-19, Zhu et al. Did a retrospective cohort study. This is published in The Lancet. And what they found was that the median duration of viral shedding was 20 days, with an interquartile range between 17 and 24 in survivors. But in non-survivors, it was detectable until death. The longest observed duration of viral shedding, 37 days. The shortest was 8 days. But again, interquartile range is, as I said. This prolonged viral shedding provides a rationale for a strategy of isolating of infected patients. So it's interesting to me that we've latched onto this 14 days, sending people home, and when really it can be shed for another 20 days. So if we send somebody home from work, they've been diagnosed that they have COVID, COVID-19, and we send them home for 14 days, and then they come back. Well, they're still shedding potentially. They might not be. Maybe they're in that shorter cohort, but probably not, because the 50% are in that we're in that 17 to 24 range. So again, a lot of this information, there's going to be more and more coming out, and I think we need to do the best we can with the information that we have, and all of these things are things that we need to be thinking about. So some additional information from this cohort study, they had 191 patients, 54 patients died during hospitalization, 137 were discharged. Median age was 56. The interquartile range between 46 and 67, and you can see the range from 18 to 87. Most patients were male. Now those are similar findings by Huang et al. Comorbidities, so here you have it. With this study, it was hypertension, diabetes, chronic respiratory illness, and coronary artery disease. The median time from illness to onset, so before admission, to discharge was 22 days, so 18 to 25 days. So this is not, 2 days come in, 2 days there, and then 2 days you're better. This takes its time to get through. The median time to death from onset was 18.5 days. 32 patients required invasive mechanical ventilation, of whom 31 of them died. So you can again, that goes with the picture of that very high case fatality rate for the severe cases that we saw in that earlier study. Half of non-survivors experienced a secondary infection. Ventilator-associated pneumonia occurred in 10 out of the 32 who required mechanical ventilation. The frequency of complications were higher in the non-survivors compared to the survivors. The most common symptoms, fever and a cough, followed by sputum production and fatigue. Sepsis, the most frequently observed complication, followed by respiratory failure, ARDS, heart failure, and septic shock. Lymphocytopenia occurred in 77 out of the patients in this study. That was 40%. Huang et al. Found that it was 26 out of their 41, so 63%. So again, we know that increasing age increases risk of death, but also this lymphocytopenia, leukocytosis, increases risk. Elevated ALT, lactate dehydrogenase, increased troponin, creatine kinase, D-dimer, and interleukin-6, prothrombin time, and creatinine and procalcitonin were also associated with death. So this virus attacks your immune system, it attacks your liver, it attacks your heart, it impacts your kidneys. And what's really interesting to me, the lymphocytopenia for one, because that to me is that to me is reminiscent of HIV. D-dimer and the prothrombin, what is it that is creating a coagulopathy, basically? So this is really this is important information, I think. So in closing, for these authors, older age, a higher SOFA score, so that is a scoring grid for sepsis, and a D-dimer greater than 1 microgram at admission is associated with increased odds of death. So to finish up here, I've got a few more. I know there's just so much information, but this is one of the more important ones, testing and reporting data when it's done well and when it's not done quite so well. So in the trajectories that we've looked at earlier, we've pointed out that South Korea has done a really good job with their case fatality rate. Their trajectory is maintaining a fairly steady plane. So what did they do right from the get-go? And I know this is not the clearest of pictures, but if you look on the grid way over to the left, those are the dates on the x-axis here. So we're starting at 120, so January 20. So at the same time, around the same time, um, South Korea confirmed a case of COVID-19, and so did the US. So what South Korea did is they started testing. So that's what this blue line is. This blue line is all the tests that they did, and they are up in the 8,000, or these are the positive cases that they got from the testing that they did. So those are 8,236 cases. But what you're going to notice, and not only did they test, but they also implemented containment strategies early on, and then also mitigation strategies. So the green bars are the newly confirmed cases, and you can see that they're increasing, and then they start to drop off. So here on March 16th, they only had 74 new cases that day. And that is really, across the board, that is very impressive. As a result of this testing, we have some excellent data coming out of South Korea. And they are willingly sharing their data. I believe they're sharing it daily. But what we found that's so interesting, I've circled it there on this bar graph that's created by a gentleman named Andreas Backhaus. We find that age 20 to 29 carry 29.9% of those carry the virus. Now, they're in the age group that has the least amount of disease, and it is hypothesized that these are those asymptomatic carriers that you may have heard about. And are they the ones that may be more efficient at transmitting it? That's currently under, they're looking at that. You might hypothesize that if you're feeling fine, that you go about your business and you connect with a lot of people. If you're not feeling well, you're symptomatic, maybe you'll be more prone to stay home and not connect with so many people. So in terms of testing approach, South Korea, they tested everyone. They did not wait for somebody to present with symptoms. They said, we want to do random testing across the board so that we find out what we're looking at here, what we're up against. And so at one point they were testing 15,000 a day. And as I mentioned earlier, their case fatality rate, along with the testing and the mitigation, containment and mitigation strategies they used, they are still below 1%. Italy, on the other hand, tested only those who exhibited symptoms, were not as aggressive with their containment or mitigation measures. And just doing a quick calc earlier, they're sitting at around 9%. So this chart is from the Wu and McCugan paper that we looked at a little bit earlier, looking at the important lessons from the coronavirus disease outbreak in China. It's the summary of the 72,000 or so. It's the case series. And so what you can see that they've done, they've gone back to December 8 and moving on forward. And in the area here where we don't have enough cases, they've rearranged the scale. But you can see that as you've got the date of onset of disease, and then you also have by the date of diagnosis. And they also have everything lined up, and when the market closed, when they identified the virus, and when they had it sequenced, and also when they had it shared. I like that they point that out. And also, they also indicate when they shut down the city. And you can see after that shutdown, and that was on January 23rd. So following that, the peak follows that, and then it starts to drop off. The diagnosis increases, but the actual amount of disease starts to drop. And so I think this is really, really excellent data showing that their measures, although we may not agree with all of those, their measures were effective. They actually did achieve what they set out to do. So then we get to the CDC data from the US, and I apologize, my little arrow is a little bit, something happens with formatting when it gets put into VoiceThread, I find. But so what we're looking at here, if you look at the date underneath, we're going from February into March, and you can see it's the number of new coronavirus disease cases reported daily. And so we have a total here N of 4,226, and it's from February 12th through March 16th. So I'm wondering where the February 12th through the end of February is. And you notice there's a star, like there's a little star and another tag. So let's look down and see what it says. Well, the star says includes both cases confirmed by state and local public health laboratories. All right, and the other marker there, cases identified before February 28th were aggregated and reported through March 1 through 3. So we have effectively erased February and part of January, where we are not characterizing any cases reported because there was really pretty minimal testing going on throughout there. So they're further looking at this same data and they're looking at hospitalizations, ICU admissions, and deaths by age group. Again, we have the same time frame, February 12th through March 16, and they've divided up the ages from 0 to 19. They got 20 to 44, and then they got 45, 55. So they have one group with that covers 25 years. The other ones cover 10 years. And what's interesting about that is the 20 to 44 have a high rate of hospitalizations when you look at between the 45 and the 64-year-olds. And so that was interesting to me. Now, the other thing I'm looking at as well is they make notations underneath here that there's a lot of missing data, missing or unknown. And we're talking pretty much half the data is missing or unknown. Looking at this information. So here is the table associated with that bar chart. And now we're looking at a total of 2,449 people, not 4,000 something. So where did that go? And the issue I have here is only having that number. The US has 327 million people. I don't think we're able to make any kind of statement about case fatality based on such a small sample. So the moral of the story is we need to do more testing. It is underway, I understand that. But to be honest, we did not take the opportunity that South Korea did. So we're behind, and we're going to have to work really hard to try to get some accurate information on board. So what I'm pointing out is, this information that South Korea took a very different approach than what the United States has. And, we're behind at this point. And Eric Topol, he's another one of the epidemiologists that I follow, feels that this is going to go down as the biggest breakdown in the U.S. response to the COVID-19, this lack of test kits. South Korea and the U.S. had their first patients on January 20th and the 21st. And just look at the difference in daily testing. By March 4th, South Korea was at 18,000 a day. So we have a big uphill to climb, and I think even more so how important it is for us to work on physical social distancing. So in terms of testing, South Korea has tested more than anyone, but Germany's right up there as well. And they also have a case fatality rate that is not far off South Korea's. United States, that shakes out to about 313 people per million that have been tested. So I think we do have a ways to go with that. So the long and the short, we went all of February, part of January, where only the CDC labs could process any of the specimens that were sent to them. We finally got the public health labs involved. That got ramped up towards the end of February, as you can see. And then by March, it looks like 13 or 14, those labs no longer need to do confirmatory testing at the CDC. So we're heading in the right direction, but what's concerning is what the shape of that curve actually looks like at the moment. So seeing this, it's hard not to marvel at the awesome power that 30,000 letters of nucleic acid have unleashed. What a little set of genetic instructions can do to this fragile, interconnected world we've built. This is from Cooper Schmidt. He is a journalist for Science Magazine. And truly, truly, I don't think I've felt this way about anything, I think, in my life. This is not something I ever expected, although the epidemiologists did. They just didn't know when. They knew it was going to. But I think the important piece here is that we all do have a part. We do understand the fragility, but we also understand the interconnectedness. And I think especially here in our community. So I think that's needs to be a huge focus for us as we move forward. So I'm bringing back the cats because we got a cat in the curve. Physical distancing, washing our hands, all that stuff. But some of the things I've been thinking about from what I was reading, especially from today, from Italy, that we really need to start thinking and actually get moving on thinking about community-based care. How can we do that? How can we make it so that these folks can stay at home but still have a connection so they can connect with somebody and say, yeah, you sound like you're okay, very good, or, you should probably get in and get seen. What's really frustrating to me is a lot of the recommendations from the CDC says, oh, don't go to the hospital, go to your doctor. Don't go to your hospital, go to your doctor. And I'm thinking, well, that's not helpful because then we're not physically distancing anything. So community-based care from some sort of telemedicine approach might be what we need to implement, not unlike what we've just gone through over at NMU, where we've had to just turn everything around. And, the big challenge I've had in the last week and a half is how do I make a, clinical lab be remote? So there's definitely that. We need to problem solve around those types of things. The other part is knowing there was such huge amounts of nosocomial spread with SARS Classic and MERS, we really need to think carefully about that, especially against the backdrop of the lack of personal protective equipment. Just like my son warned me of many months ago, it is actually here. It is exactly what he said. And I atmosphere for my coworkers, people that I love to work with, and and for myself, for my husband, those of us in the front lines, I feel that we're not prepared well enough from that perspective, especially with the research that I've been able to do. So, what I really look to and pin my hopes to is community. And to be honest, if anyone's got community, it's us. We are our community. And I think that is what has to come through 100% as we work towards mitigating this disease. Anyway, thanks for your time. I know this is a lot of time, but thank you. And what I'm planning on doing, I got a lot of references with a lot of links which you can't access on VoiceThread. So what I want to do is get that uploaded as a PDF so that you can actually, if you're interested, you can click on those links and go to those things that I've been looking at. Anyway, thanks again.